Chapter 11, the Reproductive System, Part B. The female reproductive system. We're going to do a brief overview of the physiology of the female reproductive system. The ovaries, which are the female equivalent of the testes, are responsible for the production of ova and the secretion of female hormones. Menarche is the beginning of the reproductive life for a woman, and refers to the specific moment of the onset of menstruation. This period begins generally between 11 and 15 years of age. Ovulation refers to when one follicle matures and migrates to the surface of an ovary, where it ruptures and expels the mature ovum into the pelvic cavity. The fallopian tubes serve as ducts for the ovaries, even though they're not directly attached to them. The union of an ovum and a spermatozoon, referred to as fertilization, normally occurs in the fallopian tubes. In the next few days, the resulting embryo reaches the uterus, where it begins to implant itself in the endometrium. Occasionally, implantation occurs in the fallopian tube or pelvic cavity instead of the uterus, and this results in what's referred to as an ectopic pregnancy. PID stands for pelvic inflammatory disease, and this is an inflammation of the pelvic reproductive organs. It's usually the result of venereal disease. However, it could also develop from an unsterile abortion or delivery, or even multiple sexual partners, or it could even be a complication of intrauterine devices. If not properly treated, the spread of the infection to the fallopian tubes may cause fibrous adhesions that obstruct the inner portion near the uterus. Other complications could be peritonitis, formation of a pelvic abscess, pyosalpinx, and after treatment would be hydrosalpinx. And even further obstruction can result in infertility or ectopic pregnancy. Ultrasound is the imaging procedure of choice for detecting PID and pelvic abscesses. The transabdominal approach, which is what we see here, best demonstrates the extent of the disease process, whereas the endovaginal approach is most sensitive for detecting dilated tubes, inflammatory changes, and abscesses. The fluid-filled urinary bladder provides an excellent acoustic window by displacing confusing loops of small bowel. Pyosalpinx and tubo-ovarian abscesses are typically seen as tubular adnexal masses that are sonalucent and compatible with fluid collections. However, abscesses may also have thick and irregular or shaggy walls or contain echoes or fluid levels representing the layering of the purulent debris. HSG, or hysterosalpingography, is a radiographic procedure that assesses the status of the fallopian tubes. During this procedure, the uterine cavity and fallopian tubes are opacified after the injection of contrast material into the uterus. In a woman with normal patent fallopian tubes, contrast material extravasating into the pelvic peritoneal cavity outlines the peritoneal surfaces and often the loops of bowel within the pelvis. If the fallopian tubes are occluded by fibrosis from a PID or developmental anomalies, there is no evidence of the contrast material reaching the peritoneal cavity. Now we're going to talk about ovarian cysts and tumors. Ovarian cysts are the most common in the female infant and women of childbearing age. There are two types: they're follicular cysts and corpus luteum cysts. Polycystic ovarian syndrome is characterized by multiple ovarian cysts which may interfere with the physiology of the ovary. This is considered the most common genital disorder in young women. On ultrasound, ovarian cysts appear as rounded anechoic adnexal masses. The ultrasound image demonstrates a large 5 by 6 centimeter sonalucent mass with back wall enhancement involving the right ovary. In another patient, the longitudinal image of the right ovary demonstrates a septated mass with homogeneous sonalucent components measuring 5 by 6.7 centimeters located posterior to the bladder. MRI is only used when ultrasound findings are indeterminate. In this case, the cysts appear hyperintense to the T2-weighted pelvic images because of the fluid within them. Primary cyst adenoma of the ovary often contains depositions of calcium carbonate located in the fibrous stroma of the tumor that can be detected on plain abdominal radiographs. These calcifications appear as scattered, fine amorphous shadows that are barely denser than the normal soft tissues and therefore can be easily missed unless they are extensive. On ultrasound examination, cyst adenocarcinoma typically appears as a large cystic mass with internal septa. It may be difficult to distinguish cyst adenocarcinoma from cyst adenoma. On these ultrasound images, we demonstrate cyst adenomas, which are benign. Ovarian carcinomas usually spread by implanting widely on the omental and peritoneal surfaces. This pattern can produce the characteristic CT appearance of an omental cake, and that's an irregular sheet of soft tissue densities beneath the anterior abdominal wall. PET may be used in determining the recurrence of ovarian carcinoma. In the images shown here, the PET scan revealed a solitary focus of intense FDG uptake that was suggestive of an active neoplasm and consistent with regional recurrence of the patient's ovarian carcinoma. The finding resulted in a change of treatment, and the tumor focus identified by PET FDG to be in the right posterior pelvis was successfully resected. A germoid cyst, referred to as a teratoma, is the most common type of germ cell tumor. It contains skin, hair, teeth, and fatty elements, all of which derive from ectodermal tissue. These cysts are of no clinical significance unless they grow so large that they produce symptoms by compressing adjacent structures. Approximately half of all ovarian dermoid cysts contain some calcifications. This is usually in the form of a partially or completely formed tooth. An example of that partially or completely formed tooth is shown in this image. And notice the lucency of the mass, which is mostly comprised of fatty tissue. The most common ultrasound appearance of a dermoid cyst is a complex, primarily solid mass containing high-level echoes arising from hair or calcification within the mass. In this image, we're looking at a sagittal sonogram that demonstrates only the near wall of the dermoid because the acoustic shadowing from a hairball, producing the so-called tip of the iceberg sign. A KUB demonstrates two tooth-like densities beside the coccyx. And the transverse sonogram demonstrates a heterogeneous mass with a high amplitude echogenic focus as a result of the tooth-like densities. Uterine fibroids are also referred to as leiomyomas. They are benign, smooth muscle tumors that are very common. They're also very multiple and vary greatly in size. The growth of these tumors is stimulated by estrogen. They develop only during the reproductive years and tend to shrink after menopause. The most common symptom is abdominal bleeding between periods or excessively heavy menstrual flow. Uterine fibroids are by far the most common calcified lesions of the female genital tract. They have a characteristic mottled, mulberry, or popcorn type of a calcification and appear in plain abdominal radiographs as smoother lobulated nodules with a stippled or whorled appearance. A very large calcified fibroid occasionally occupies the entire pelvis or extends out of the pelvis to lie within the lower abdomen. During expiratory urography, persistent uterine opacification is often seen in patients with an underlying uterine fibroid tumor. On this image, we demonstrate persistent dense opacification of acute uterine leiomyoma. The classic ultrasound appearance of a uterine fibroid is a hypoechoic solid contour-deforming mass in a large inhomogeneous uterus. In the longitudinal sonogram demonstrates a pedunculated leiomyoma as a hypoechoic mass projecting from the fundus of the uterus. Decreased sound transmission to the mass indicates its solid nature. Endovaginal or transvaginal ultrasound is the best modality to demonstrate small and submucosal uterine fibroids. And this endovaginal ultrasound image of the uterus in the sagittal plane demonstrates a fibroid filling the superior endometrial cavity. MRI is more sensitive than CT or ultrasound, but is indicated only when ultrasound is inconclusive. And this T2-weighted MRI sagittal image demonstrates a sharply marginated fibroid in the uterus fundus that contains both high and low signal intensity. Endometrial carcinoma is referred to as an adenocarcinoma of the endometrium and is the most common invasive gynecologic neoplasm. It usually occurs in postmenopausal women, especially those who've never had children. And the condition presents with postmenopausal bleeding. The typical ultrasound appearance of endometrial carcinoma is an enlarged uterus with irregular areas of low-level echoes and bizarre clusters of high-intensity echoes. This endovaginal sonogram localizes irregular endometrial thickening with echogenic polypoid projections into the fluid-filled endometrial canal. CT demonstrates focal diffuse enlargement of the body of the uterus. This CT scan shows a mass obliterating the fat planes between the bladder and the uterus. Urine within the bladder outlines thickening of the posterior bladder wall. Nodular extension into the ischiorectal fossa indicates local extension of the tumor. MRI allows differentiation of the endometrium from the myometrium of the uterus and has been shown to be useful for demonstrating focal or diffuse endometrial tumors. In this sagittal T2-weighted MRI scan shows extensive tumor of mixed signal intensity that has invaded the endocervix and permits identification only of the ectocervix. Endometriosis is the presence of normal appearing endometrium in sites other than the normal appearance within the uterus. Clinical symptoms include abnormal bleeding, painful menstruation, and pain during sexual intercourse. Although the endometrial tissue lies outside the uterus, it still responds to hormonal changes and undergoes proliferative and secretory phases, along with sloughing and subsequent bleeding. Thus, an endometrial implant within a closed space can continue to grow with each menstrual cycle. The endovaginal sonogram demonstrates diffuse, homogeneous, low-level echoes throughout the cystic mass. In the GI tract, endometriosis primarily affects those segments that are situated in the pelvis, especially those in the rectosigmoid colon. It typically causes abdominal cramps and diarrhea during the menstrual period and may appear as single or multiple masses within the colon. Carcinoma of the cervix is the third most common form of cancer in women. It has a tendency to be related to chronic irritation, infection, and poor hygiene. Diagnosis can be made by use of a pap smear. Early stage is surgically curable. In the advanced stage, it becomes inoperable and radiation therapy is the usual treatment. Ultrasound usually demonstrates a cervical carcinoma as a solid mass behind the bladder. This sonogram demonstrates a solid echogenic mass lying behind the bladder that is indistinguishable from a benign cervical myoma. CT is more accurate in detecting pelvic sidewall invasion and therefore is usually the initial screening procedure in patients in whom there is a clinical suspicion of advanced disease. In the CT axial scan, we're looking at the enlarged cervix without evidence of bladder invasion. In the second CT scan shows irregularity of the posterior margin of a contrast-filled urinary bladder in the adjacent inhomogeneous cervical mass. MRI is of value in detecting and staging cervical carcinoma. The MRI sagittal T1 weighted image demonstrates posterior cervical lobulation as the only sign of an infiltrating cervical neoplasm. In the sagittal T2 weighted MRI image shows a bulky cervical neoplasm with mottled high signal intensity. The lesion has invaded the upper third of the vaginal stroma anteriorly and posteriorly, but it has spared the uterus. The urethra and the cervical bladder are anteriorly displaced by the tumor. Breast lesions. Most breast tumors are classified as infiltrating duct carcinomas, which occur most frequently in the upper lateral quadrant. Breast cancer is the most common malignancy among women between 44 and 50 years of age. Breast cancers diagnosed in stage 1 have a patient survival rate of approximately 98%. Unfortunately, most breast cancers are discovered accidentally rather than in the course of regular survey examinations. By this time, the majority have spread either to the regional lymph nodes or systemically, accounting for the regional high mortality of approximately 50% that makes breast cancer the leading cause of death in women. Periodic, careful physical examinations of the breast done either by a trained health professional referred to as a clinical breast examination or by the patient referred to as breast self-examination will discover cancers that are small and more likely to be localized. Even smaller, non-palpable, but potentially more curable lesions can be detected by mammography. Almost every breast cancer is seen on mammograms as a tumor, mass, cluster calcifications, or both. Either feature, when clearly demonstrated, is so indicative of malignancy that prompt biopsy is required whether the lesion is palpable or not. Secondary changes of breast carcinoma include skin thickening and nipple retraction. Magnification imaging and compression techniques greatly improve the diagnostic value of the image. The typical malignant tumor mass is poorly defined with areas of distortion, has irregular margins, and demonstrates numerous fine linear strands or spicules radiating out from the mass. And we can see that in both the right and left CC views as well as the MAG view in these images. Cluster calcifications of breast cancer are typically numerous, very small, and localized to one segment of the breast. They demonstrate a wide variety of shapes, including fine linear, curvilinear, and branching forms. Ultrasound provides a secondary diagnostic tool that can differentiate a benign cyst from a solid mass, and thus it substantially reduces the number of biopsies performed for benign cysts. Mammography using magnification spot compression demonstrates microcalcifications in a spiculated lesion in this image. Then the breast sonography shows finger-like projections emanating from the lesion measuring 1.8 by 1.25 centimeters. The imaging appearance is a well-defined smooth margin and round, oval, or gently lobulated contour. This mammogram shows several rounded masses that could be solid or cystic in a breast that's very dense anteriorly. The sonogram clearly shows that the largest mass is cystic because it contains no internal echoes and shows considerable posterior enhancement. Breast implants can be visualized in both mammograms and on MRI scans. On the left-hand side, we see the ruptured silicone breast implant that was visualized on a mammogram. And then on the right-hand side, we can see where the MRI distinguishes well between the breast tissue and the implant. That is the folded one implant that is visualized. Because of its non-invasive and non-ionizing character, ultrasound is a modality of choice in the evaluation of possible complications of pregnancy. A major role of ultrasound is to assess the gestational age, a measurement that is often highly inaccurate when based on the date of the last menstrual period. Measurements of fetal age by ultrasound include. An early diagnosis of multiple pregnancies can be made by ultrasound. This is essential so that therapeutic measures can be taken to reduce the high complication rate associated with twin or more fetuses. And the endovaginal sonogram demonstrates 2 gestational sacs. On the right side, we can see the large abdominal radiograph of a woman with quadruplets that clearly shows 4 separate fetal skulls and spines. This concludes Chapter 11 on the reproductive system.